Okay, class. In this lecture, we'll get into some of the exercise responses to our blood pressure responses to exercise, or the exercise responses of blood pressure. So, just a quick review again from normal physiology and exercise physiology. That as we exercise, cardiac output obviously increases linearly with cardiac with oxygen consumption. We see substantial increases in heart rate, modest increases in stroke volume, which of course, again, level off at around 60% of our VO2 peak. And heart rate kind of takes us the rest of the way, right? Remembering that cardiac output, of course, is stroke volume times heart rate. The initial response to exercise, the first, within 5 minutes, we really see, again, that withdrawal of parasympathetic tone, which results in an increased, sympathetic response, right? So we see withdrawal of the baroreceptors, vagal control, which, everything's always in balance. It's not like you switch on and off sympathetic, parasympathetic. They're always in balance, or we often call the sympathovagal balance. So at the beginning of exercise, we see that parasympathetic control withdrawal. And we think maybe there's feed-forward mechanisms into some of these blood pressure responses, but either way, we see, again, that sympathetic response due to the withdrawal, primarily of parasympathetic control and the baroreceptors. As we continue to exercise, we've got that steady state, sympathetic nervous system activity continues to increase, and we start seeing, again, even at the onset, but particularly at the state, we see that global vasoconstriction, and the way we are able to orient or redirect blood flow to tissue, because again, sympathetic outflow to the peripheral vasculature is going to cause vasoconstriction, right? Primarily looking at our alpha-1 receptors, with the effects of noradrenaline. Now, with exercise, we produce metabolites. There's also shear stress along the endothelium, which stimulates endothelium-derived nitric acid synthase. So we end up having that local vasodilation in active working tissues that offsets that global sympathetic response. So we have this functional sympatholysis. Again, remembering lysis means to split or to break. And that's we're breaking or splitting the sympathetic nervous system's effects on the local vasculature through these metabolic, mechanical, and fluid-mediated factors, which helps us, again, redirect blood flow to working tissue by decreasing the vascular resistance and thus increasing flow. Things move towards lower resistance. We have lower resistance in those working tissue and higher resistance in non-working tissue. We're going to end up seeing blood flow to those working areas. So we see very low total peripheral resistance in working muscles. Now, in terms of blood pressure and heart rate responses, again, remembering blood pressure response, we'll typically see a 10-tick increase in blood pressure for every 1 met. So if we move from rest to maybe walking, we should see blood pressure maybe go up roughly about 10 millimeters of mercury. Diastolic blood pressure should not change much at all. And in fact, at most 10 millimeters of mercury, even at maximum, right? It might even decrease, remember, because diastolic's more, in response to, it's more, the resting pressure, we should see actually decrease because total peripheral resistance begins to decrease as we exercise. Systolic will go up because systolic blood pressure is tightly related to stroke volume. It's often, analogous. So as we exercise, again, stroke volume increases. So we should see systolic blood pressure progressively increase. Diastolic blood pressure, again, is really the resting pressure in the vessels. And that should actually get a little bit lower or not change much at all during exercise. And again, if that goes up, that's not a good sign. It means, something's not moving normally through the vasculature. Heart rate response follows the same rules, about 10-tick increase per change in MET. These trends in heart rate and blood pressure might be a little bit different in older populations. Should still be progressive without a significant change in diastolic blood pressure. Now, it's important to note that again, with upper extremity activities compared to lower extremity activities, you're going to have a higher response with upper extremity activities. And that's because of that functional sympatholysis. When we are exercising our upper extremities, only the blood vessels in our arms, right, if we're doing like an arm bike, for example, are going to be working. And that's the only vascular beds that are really going to be undergoing that functional sympatholysis, where our lower extremities, aren't. They're going to be constricted because of that global sympathetic response. Because our legs typically are bigger than our arms, they have a much larger vascular bed. So we typically see a little bit more exaggerated blood pressure response with an upper extremity exercise compared to a lower extremity exercise. Because say, for example, if we were doing a seated bike, right, a recumbent bike, and we were pedaling, that would be working out our legs. Our upper extremities would, again, in that example, not be moving much, aren't active. So the vessels in our upper extremities when we're cycling, doing a lower body ergometer, would be, those vessels in the upper extremities would still remain constricted, whereas our lower body, our legs, would be dilated because they're working, they're active, producing metabolites, and would be dilating. So we would see, a lower blood pressure response compared to a lower blood pressure response with a lower extremity exercise compared to upper extremity exercise. And it all has to do with, the muscles that are active and thus the vascular beds that are either undergoing vasodilation through that functional sympatholysis and the amount of vessels undergoing constriction. Again, with a lower body exercise, you have more vessels undergoing dilation because the lower extremities are bigger than your arms, right? And then the opposite, right, with upper extremities, right? Both will be progressive, but the net increase in blood pressure will be a little bit lower with a lower extremity exercise. That's why it might be advantageous potentially to start with a lower body program, maybe someone with hypertension. Whole body will have the lowest net increase because all the vascular beds in the muscles, because all muscles are working with whole body exercise. So all those all the vascular beds in the muscles will be dilated. So you have the lowest net increase. Now, again, we think exercising blood pressure might be more useful than just static blood pressure because, again, we're looking at how the body is responding to stress. The same concept as we look at for biomechanics or posture. Like static posture, not super useful, not super predictive of maybe, acute injuries. I want to see how the body responds to stress, right? Exercise is a physiological stress. I want to see how does your blood pressure respond? Is it an exaggerated response? Because we're actually finding, and we'll show some work from Dr. Sabahi, that hypertensive patients often have an exaggerated response. I want to see how they recover, right? Maybe if someone has a normal resting blood pressure, an exaggerated response is predictive of future hypertension. So I really want to make sure we're appreciating the value of looking at blood pressure responses during exercise. So we have some technique here. We'll go over this kind of in lab, but you're going to be following these instructions here. And it's almost the same exact setup as you would with a standing blood pressure, but you're doing it while someone's moving. And we'll go over how to do this in lab. Now, in terms of recovery, heart rate, we have this in here because it kind of works, with this blood pressure lecture, but heart rate, greater than 12 within a minute, resting levels 2 to 3 minutes. Blood pressure, again, we should see roughly a 10 millimeter mercury decrease in systolic because, again, diastolic shouldn't have changed much at all. So we're really looking at systolic, about a 10 millimeter decrease every minute or so. And the real marker is at 3 minutes, systolic blood pressure in recovery should decrease to what it was, to 90% of what it was at peak. So if you got to a peak blood pressure of 200 millimeters of mercury during exercise, right, your peak blood pressure, at 3 minutes, your blood pressure should be, less than 180, right? And then typically blood pressure should resume to normal or what it was at rest, in recovery or after 5 to 6 minutes of recovery. So, 10 ticks per minute or 10 millimeters per minute in recovery, less than 90% of peak after 3 minutes, and then back to baseline after about 5 to 6. Now, hemodynamics, again, we were talking about primarily aerobic exercise. The hemodynamics for resistance training, a little bit different. Resistance training is going to have much more pronounced blood pressure response. Some say it could even be as high as like in the 300s if you're doing like a maxed out lift. And we think this is due to the sympathetic constriction that you might see, obviously, with any exercise, but there's also mechanical compression, right? So if you compress your blood vessels, there's going to be, changes in blood pressure and vascular resistance. Now, the change in blood pressure during resistance training is oscillatory and related to the phase of lift. So during the concentric phase, if you're doing a bicep curl, right, the flexion component is going to have the highest increase in blood pressure. It begins to level off a little bit during the terminal phase. So if we get all the way to the end of that flexion moment during a bicep curl, it's going to kind of get back to resting values roughly at the completion of that phase. And then as we go through the eccentric phase, it'll increase again, but it's a little bit lower than the concentric phase. And the restoration of blood pressure at rest is typically similar to what we see at endurance exercise. So if you want to use that same 3 minute marker of 90% at peak, you can go for it, or baseline back to or back to baseline after 5 to 6 minutes. There really isn't a lot of work looking at acute responses to resistance training, mainly, especially for hypertensive, mainly because it was often viewed as something you would be contraindicated. We're learning that blood pressure, patients with hypertension, resistance training can be an effective option potentially as well. But again, something to be concerned about potentially if you're just starting out doing high lifts, just because, again, like we can see peak pressures go up to the 320s sometimes during very high resistance leg press. Some values are reported being as high as 480. Again, those are transient peaks, but something to consider potentially is the use of eccentric lifts, right? So again, we know, for example, that the eccentric phase compared to the concentric phase is going to have a little bit, it's going to have a lower blood pressure response. So maybe if you have a patient with hypertension, you start out with an eccentric protocol because I can still load those muscles, those joints, make them stronger. They might have a little bit more soreness because eccentric loading typically does that, but it's going to be a little bit maybe better tolerated. So if you're working with someone with some risk factors, maybe doing an eccentric approach at the start would be ideal. And if you really wanted to kind of stack things up, you could do an eccentric lower body approach, right? Because we know lower body exercise is generally going to have a lower net increase. The other thing that we need to consider is post-exercise hypotension, so PEH. This is the presence of a prolonged decrease in resting blood pressure following exercise. So we've gotten to recovery, right? They're seated, they're resting. We've gotten to that 5 to 6 minutes. And if we look at periods, at that 6 minutes onward, they may actually have a slightly lower blood pressure. And we're finding that this is dose dependent. So if people work out really hard, we typically see greater reductions in blood pressure. So the intensity, I think, matters. We think that may be due to the stimulation of enos, right? If we're working really hard, that blood is really moving quickly along the endothelium. We have all that shear stress, stimulates enos, which produces nitric oxide, which is a vasodilator. All those local factors still stay active for a little bit. So, even though in recovery, right, when we pause and take a rest break, we've got that, heart rate comes down, right, and we had that functional sympatholysis. Well, it takes a little bit while for those metabolic byproducts to kind of clear, and we may actually have them still acting. So that's what we think may explain this lower or prolongation in reduced blood pressure because we lower the vascular resistance. The great thing is in patients with hypertension, they see the greatest post-exercise hypertension, or at least you're more likely to see PEH in someone who's hypertensive compared to someone maybe who with normal blood pressure. And we actually find this could be a useful tool, because if someone with hypertension demonstrates post-exercise hypotension after exercise, it's a pretty strong prognosis that they're going to respond well to an exercise program to improve their blood pressure, which is great for us, meaning that maybe we should be considering the use of exercise measurements, or at least measurements in recovery after someone works out or warms up in our clinic, to see, well, maybe they get a little bit better acutely, and this person would benefit from just a basic activity program to help treat their blood pressure. Something to think about. The other mechanism too, in addition to that functional sympatholysis still acting, we think it may be due to the barrier receptors also reset during exercise. So that could be a component of as well. So the Valsalva maneuver, we're just going to touch on this very briefly. This is when we see intrathoracic pressure becomes very positive, like when we're bearing down. It happens with defecating, it happens with very heavy lifts often, where we see initial compression of the thoracic aorta because we're bearing down, which again, when we have compression, we typically see pressure increase. With this, we also see concomitant decrease. Now, what also happens with this concomitant compression is there's also compression of the vena cava. So we have basically we push a little bit of volume, into the heart, pumps it out, and the heart rate drops. So as aortic pressure begins to fall after a few minutes of compression, because cardiac output's falling because pressure is continuing to compress on the heart and the aorta, as the person begins to breathe normally, the aortic pressure briefly actually decreases as we remove that external compression, and the heart rate actually goes up a little bit, right? And causes, we're seeing that mean arterial pressure drop. So again, basically the breakdown of Valsalva is when we bear down, pressure increases briefly, heart rate drops as we can, are continuing to bear down, pressure begins to drop, heart rate tends to increase, and then we potentially have this critical period where either we have too low of a pressure or too high of a heart rate, or too high of a heart pressure or too low of a heart rate, and we end up passing out. So it causes very large fluctuations in mean arterial pressure and heart rate, which for some individuals can be problematic. So that's Valsalva in a nutshell. Now, next we'll get into some abnormal events, exercising hypertension, hypotension, and adverse events. So hypertensive responses or exaggerated responses of blood pressure, we often call HRE, or hypertensive responses to exercise. These have been demonstrated typically or looked at maximal responses. However, we're finding this may even be identified at lower intensities. And again, we found that it may be useful for looking at blood pressure responses at low intensity, even in normal patients, because there are some patients that may have a normal resting blood pressure that have an exaggerated response, and which can be predictive of a future hypertension diagnosis. Or it may unmask people that have masked hypertension who are actually hypertensive at home, because hypertensives typically have hypertensive responses to exercise. So either way, there's some value here. So again, it's just a plot showing again, that a normal response in the filled out line, and a hypertensive response. So according, depending on the intensity, we should see blood pressure increase, whereas someone with a hypertensive response, it'll be much, much more pronounced. And again, we're typically this was looked at this part of an exercise test at high intensity, but we're finding that it may even be identified at low intensity, like 5 METs or less. And the earlier we observe it, maybe it's even worse. Again, there's no other profession that's really able to serially assess this besides PTs. So I think we have a role here in potentially looking at exercise responses just from something we typically do, like have someone warm up on a treadmill or on a bike, throw in a blood pressure cuff, and maybe we can actually see what's their blood pressure response. And maybe something's normal, maybe it's not. Something which could be a valuable tool for prognosis and for management. And then again, this is work by Ahmed Sabahi showing that maybe there's differences in terms of, peak responses based on age. So we're finding that, again, for many years, it was based on just this raw number, 220, and 190 for women. However, if we look at differences in age, right, like the peak pressures, right, for someone who's 70 years old, right, that's going to be a little bit different, right? There's different trends. We typically see it trend up, and we say that the 95th percentile is an exaggerated response. We may end up seeing just a difference according to age. So maybe we should match our guidelines to age and gender to be a little bit more specific in terms of our diagnosis, and as well as moving things earlier, looking at just at moderate intensities. Now, hypotensive responses or LowExBP, so that's the opposite. And remember we mentioned that systolic blood pressure is pretty strongly correlated to stroke volume. We should always see a progressive increase, especially during aerobic exercise. Now, there are some individuals where their blood pressure does not increase and actually decreases, and that's predictive of cardiovascular events, mortality, and the earlier we demonstrate, the worse off they are, and because that really reflects that the ventricles, right, especially the left ventricle, is just not able to keep up, not able to match stroke volume or cardiac output or pumping performance to intensity. And this just, again, shows the value of taking these measurements during exercise, because static measurements absolutely useful. A measurement pre-exercise and post-exercise, useful, right? During exercise, that's the real value, because I want to see how are they acutely responding to stress. And again, we think there is definitely exaggerated responses and then these hypotensive responses. And the earlier we see them, and we can even get it during low intensity, for both hypertensive and hypotensive, so HRE and LowExBP, the earlier and even the lower intensity, the worse the prognosis. And again, we can assess this in our clinics already. So in terms of adverse events in hypertension, again, I don't want to scare people that patients with hypertension can exercise. The risk of cardiac events are fairly low, especially for monitoring. But we need to be monitoring, right? And to be dosing patients appropriately. And we can't dose patients appropriately if we aren't even taking measurements at baseline. So, that's kind of my, little soapbox there. And there's just an example of what we can see in terms of cessation exercise and these adverse events. Now, pediatric considerations, so abdominal aneurysms can cause differentials in blood pressures. And probably the biggest concern is any child with hypertension or abnormal blood pressures should always be a red flag. Kids should have, there's guidelines that I provided earlier on, but if any child with hypertension, that should make you think of coarctation of the aorta. It's probably one of the leading causes of it, which causes this pulse differential. So the pulses we appreciate in the upper extremity versus the lower extremity a little bit different, and they'll have this hypertension, which is an abnormal finding. Hypertrophic cardiomyopathy, you may also see this as well. Resting pressures may be elevated, and they may have an impaired systolic response to exercise. So again, it's not a pediatric focused course. We'll cover congenital defects later on, but it's want to let you know there are, we should be screening in kids too, because there are, while it's rarer to find cardiac conditions in the kids, there are hypertension in the kids. It does happen. As kids become more inactive and more obese, it's happening increasingly. And there are congenital defects that we could pick up from an abnormal blood pressure in a child. So with that, we'll end here, and then we'll get into how do we put this all together in a PT practice.